taking your lunchtime out to listen to my talk. So today I've been asked to speak about the side effects of CAR T treatment and their management. And I will take you through about 37 slides in the next maybe 40 minutes. And if there's any questions, do feel free to type it into the Q&A box. Okay, so as a general introduction, what is CAR T? So essentially, we're actually genetically engineering live cell, a living drug, where we put in basically an extracellular antigen binding domain to a signaling element of the CD3 zeta. And all these, we actually use viral vectors and we put it into a patient's cells, and the final product becomes what we call a CAR T cell. After we manufacture this product, we actually reinfuse it back into the patients, and it finds its way into the tumor cells, engages the tumor cells, causes cell death, and effects its killing in this way from this diagram that's taken out from a review article. Okay, so why is everybody talking about CAR T? How has it revolutionized clinical medicine? Essentially, in adult patients with B-cell acute lymphoblastic leukemia who have relapsed post-allogenic transplant, traditionally they have median survivals of only about 7 months. And in the earlier trials, they showed unprecedented results with CAR T. More than 80% of patients with relapsed refractory disease actually achieve complete remissions. And up to 50 to 86% of these patients are actually still alive at 1 year. And that was a very remarkable result. And all this led to further development of the CAR T therapy. Now, in patients with B-cell lymphoma who have relapsed and refractory disease, the median survival initially was about 6.3 months. And following CAR T therapy, we have seen that more than 50% achieve remission, and more than half of this cohort are actually still alive at 18 months. So based on all these results, we have actually seen unprecedented results in patients who have otherwise succumbed to their disease. And this is actually follow-up results from the ZUMA, which is the axis cell. And you can see that actually there is a plateau in the curve suggesting that we may be able to almost, we can say, cure patients who have responded very well with CAR T. And this is also similar trends in patients seen on the Juliet study, which is the other CAR T chimera. You can see that actually there is a plateau in survival and progression for these patients. Okay, so we have seen that actually CAR T is really quite good and has very much improved patients who have otherwise very dismal prognosis. Now we also want to talk about what are the side effects associated with CAR T therapy. And CAR T is actually associated with unique toxicities. And the earlier clinical trials that tested CAR T in patients actually uncovered greater toxicities than other cellular therapies, indicating there was a profound and generalized immune system activation. And these earlier studies, they found that the toxicities were similar to the cytokine storms that were seen in this experimental drug, the TGN-1412, where healthy volunteers would receive monoclonal antibody rapidly develop rapid onset of multi-organ failure. Okay, so this is one of the earliest case reports from NEJM that actually showed the CAR T toxicities, and essentially 2 children with relapsed refractory ALL were infused with the CTL019. And the first patient actually had a very rapid progression to cardiorespiratory failure after developing high fevers, requiring inotropic support, mechanical ventilation. And it was in this study that in this case that they actually gave steroids, etanercept, tocilizumab, and managed to control this overt cytokine storm that the patient actually suffered. And many years later, this patient still remains in complete remission from the ALL and is very well. The second patient also developed some kind of fever and confusion, which now we know as ICANS. And this patient didn't need very much medication, and everything actually resolved spontaneously for this patient. So we can see that from the first 2 patients, what we had seen, hypotension, fevers, and some liver abnormalities. So this is the start of what we know as CRS and ICANS. So this is followed up by several larger studies that happened and were published in 2018, 2019. And this is the CTL019, which is what that the two patients got. And in the bigger study, it was associated with cytokine release and a neurological event, any grade 77% for cytokine release and neurological toxicity up to 40%. And serious cases more than grade 3, grade 4, actually quite a significant number of patients were observed to have this. And also in the ZUMA-1, which is the ACTRIS cell in refractory large B-cell lymphoma, you can see that the number of patients who got any neurological event was 64%. That's quite a large number. And also more than 28% of patients developed more than grade 3 encephalopathy or ICANS. And in cytokine release for the ACTRIS cell, you can see that 93% of patients in their cohort had some kind of cytokine release, of which about 13% had quite a severe cytokine release. Okay, so go to the next slide. Right, so what exactly is CRS or cytokine release? It's defined as a supraphysiological response following any immune therapy that results in the activation or engagement of endogenous or infused T cells and or other immune effector cells. So this is a summary table of the currently available CAR T products. Those that are actually more widely used for a longer period of time are T-cell Gen Lucel, which is the Kymria, and also the ACTRIS, I can't really pronounce it properly. So this one is also what we know as Yescarta. So these are the first two commercially approved products. And you can see that actually it's really associated with quite a significant amount of CRS over here. In the T cell for ALL, you can see that more than 46% of patients actually had a more than equals to grade 3 CRS. And also for ALL, for the Yescarta, is actually about 26%, quite higher. Now, the large B-cell lymphomas also have a significant number of grade 3, more than grade 3 CRS, but it's a little bit less than ALL, but still significant, between about 22 and 13%. Okay, so what is the pathophysiology of CRS? Essentially, with binding of the CAR T to the tumor antigens, there is release of interferon gamma, GM-CSF, which is released by the CAR T, and all these in place actually activate the macrophages, the monocytes, and also there is a CD40 ligand expressed on activated CAR T cells, and these bind to CD40 on monocytes, macrophages, and dendritic cells. And all these activation actually trigger the release of lots of cytokines, including interleukin-1, 6, nitric oxide, and all these actually leads to a cytokine release syndrome. So how does it usually present? It starts quite insidiously, just like a flu-like symptom, some aches and pains, feeling not so well. And then it progresses into a condition that resembles sepsis, fever, chills, rigors, and if we don't watch them carefully, it can rapidly result in something like a multi-organ failure with hypotension, troponin leaks, breathlessness, and actually even liver dysfunction, kidney dysfunction, very severe multi-organ failure. Fever is a hallmark and early sign of cytokine release, so we are always very careful when we have a patient undergoing CAR T and we watch them for fever very, very closely. And other early symptoms, non-specific headaches, rashes, arthralgias, myalgias, and as mentioned just now, it can progress within hours, very short period of time to hypotension, vascular leaks, DIC, respiratory failure, requiring high flow oxygen or even intubation. So usually the first symptoms occur within hours of infusion, and usually up to about 14 days after CAR T. The median time to onset of CRS is about 2 to 3 days. And very importantly, although you suspect that this patient has CRS, it's important not to miss infection, concurrent infection. So normally we would order blood cultures, urine cultures, x-rays, and we would still start them on actually broad spectrum antibiotics for patients, although we suspect that the cause of the fever is cytokine release. So there are many, many different symptoms of cytokine release. General symptoms, as mentioned, fever, aches and pains, nausea, headaches. Cardiovascular, heartbeat can go up very high. There can be arrhythmias, there can be hypotension, progressing on to shock. For respiratory, it can lead to hypoxia and almost like a pulmonary edema kind of picture. It can be very, very breathless suddenly. and it can also develop ARDS, acute respiratory distress syndrome. For blood symptoms, you can have prolonged cytopenias and DIC, where the coagulation goes very, very abnormal and they can actually bleed later. And for other target organs, can have hepatitis, a very high liver enzymes, and also renal failure, sometimes renal toxicity. So in essence, it can cause widely a lot of side effects in multiple different systems. That's why it's important to try to pick it up early to prevent it from progressing to quite a severe CRS. Right. So in the earlier days of CRS, there wasn't really a consensus grading. But in 2019, there is now a ASTCT CRS consensus grading that most centers use now, and this has superseded the LEAD-L grading system. So essentially, they try to make it easy and very useful for the clinician. And cytokine release is actually graded into 4 grades, with 1, 2, 3, and 4, with increasing severity as the grade goes up. So what's important is in grade 1, it's just a fever. There's no changes in blood pressure. There's no need for any oxygen. So those patients are categorized as grade 1. And for patients who have grade 1 CRS, normally we can afford to monitor them closely. For grade 2, it's when the patient has a fever, and on top of a fever, they actually require oxygen. And it must be a low flow oxygen. That means not requiring a lot of oxygen supplementation. Because if you do need any higher flow oxygen support, then your grading of your CRS has gone on to grade 3 and not grade 2. And we should be considering whether this patient needs to be shifted to the ICU for closer monitoring. Similarly, for hypotension in grade 2, the blood pressure is actually good. There's no need for any fluid boluses. There's no need for any vasopressors. The moment you need some vasopressors like dopamine or more adrenaline, or more heavy going inotropes, you would have to shift this patient to medical ICU, and this patient would be considered a grade 3 cytokine release syndrome. And if you require more than one vasopressor, or you require like BiPAP, intubation, and mechanical ventilation, then you would actually be what we call grade 4 cytokine release. And all these patients will be managed in the medical ICU. How is the management of CRS? It also very, very much depends on the grading of the CRS. That's why grading is very, very important. So if you're grade 1, we would just give you IV fluids, make sure you don't dehydrate. We will give you light Panadol, sponging to bring down your fever. We will consider a full septic workup, including x-rays, urine cultures, blood cultures. And we will most of the time start patients on broad spectrum antibiotics, especially if their white counts are low. And most of the time, by this period of time, they will have a low neutrophil count. The use of growth factors are not really encouraged in the beginning, as it can worsen the CRS. So we will only consider growth factors if the patient is really, really very, very sick, or else the time has passed after about 14 days have passed after the infusion of the CAR T. For patients with any hypoxia requiring low flow oxygen, or hypotension which just responds very well to fluid boluses, we will monitor them and treat them just like what we do for grade 1. But on top of that, we would actually have a very, very intense monitoring for them, maybe even up to hourly parameters, because if they are not very well, there's some signs that they're not very good, we may opt to give them tocilizumab, which is an anti-IL-6, and dexamethasone or steroids to actually manage this grade 2 CRS. For grade 3 CRS, these patients will have to be most of the time we would monitor them in the intensive care unit. Again, the same management as grade 1. That means antibiotics, fluids, medicine to control the fever. But when they reach grade 3, definitely we would give them tocilizumab and dexamethasone. That's because these patients can become very sick and we might lose them. So we will reverse them fully at this point in time. And for grade 4, we also would definitely give them tocilizumab, and we would increase the steroid to a very high dose of methylprednisolone rather than just dexamethasone. Okay, so I think the question and what people are trying to do now is whether or not we can try to prevent or reduce the severity of CRS. And we know now from certain studies that have been published that actually earlier intervention rather than later does not affect the CAR T outcomes, but actually improves the outcomes from CRS. So this is the PLET study where they compared the early intervention cohort, which is the blue, to the old cohort, which they only intervened when patients became unwell of hypotension and needed oxygen and all that, compared to what they call an early intervention cohort, where quite rapidly they're not well, they have fever, unresponsive to Panadol, they need recurrent fluid boluses, or they need any oxygen, they quickly jump in with tocilizumab and steroids. And they showed that actually there is no difference in outcome. This early intervention doesn't affect the CAR T effects, but helps to prevent serious side effects from CRS. Okay, so this is also another study where they actually gave preemptive tocilizumab, and they would give it if the patient has 2 fevers more than 38.5, at least 4 hours apart for more than a 24-hour period. And by preemptively giving tocilizumab, they found that they could reduce the severity of the CRS compared to the historical cohort. Okay, and they also showed that by doing a preemptive tocilizumab, they actually didn't see an increased rate of neurotoxicity. Okay, so they showed that this was actually safe, even in patients who had very high blasts in the peripheral blood. Okay, this was published just earlier this year in JCO. And these are also important, although in abstract format, I thought it's important also to bring up. This is the experience from the Zuma trial, which is the ACTRIS, where they actually had few cohorts because they wanted to reduce the side effects from CRS and ICANS. So in the cohort 3, these patients actually were given prophylactic Capra, and also they were given tocilizumab 2 days after the ACTRIS infusion. What they found was that by giving this dose of tocilizumab, only 1 patient had more than grade 3 CRS. But however, they did note a higher incidence of grade 3 and 4 ICANS or neurological events, 29% at grade 3 neurological events and 6% at grade 4. And they cautioned about giving prophylactic toci because they were worried whether or not this increased the rate of neurological events. Okay, so in their historical data, those patients who had more than grade 3 neurotoxicity was about 11%. So it was a bit concerning whether or not by giving this prophylactic toci, there was an increased risk of ICANS. So in their cohort 4, they gave patients steroids earlier, the moment they had any grade 1 neurotox or any grade 1 CRS. And they found that the more than grade 3 CRS was 2%, which was very good, and more than grade 3 neurotoxicity was about 17%. So they showed that all these actually improved the toxicity from CAR T, but didn't affect the outcome. That means the efficacy of the CAR T. So this is what we have currently for prophylaxis and preemptive tocilizumab and also steroids. Okay, so we move on to ICANS, which is the other side effect from CAR T that I think hematologists who give CAR T are very worried about. So how do we define ICANS? It's essentially a disorder characterized by a pathological process involving the CNS following any immune therapy that results in the activation and engagement of endogenous or infused T cells and or immune effector cells. The symptoms might be progressive, may include aphasia, altered conscious levels, impaired cognitive skills, motor weakness, seizures, and cerebral edema. So quite a handful of definitions and all that. Okay, so we can see that the incidence ranges between 30 to all the way to 46% for ALL, again more than large B-cell lymphoma. Okay, and for B-cell lymphoma ranges between 10 to 28% of serious ICANS. All right, so what is the pathophysiology of ICANS? So essentially, usually it's associated with cytokine release. So there is already a systemic inflammation and expression of IL-1. This activates the bystanding monocytes, which aggravates the systemic inflammation by activation of T cells and macrophages. There's also endothelial activation and disruption of the blood-brain barrier with migration of the T cells and CAR T into the brain, leading to elevated cytokines and proteins into the CSF, the cerebrospinal fluid. So the onset of ICANS usually follows that cytokine release. That means it happens usually after cytokine release, and the median is about 4 days after infusion, compared to cytokine release, which the median is about 2 to 3 days after infusion. The symptoms, however, do last longer than CRS also, and the median duration of ICANS normally is about 11 days. Now, symptoms in the early part of ICANS can be very, very subtle, can be just a fine tremor. They can't react very well. They have difficulty with expressive speech. They can't name objects. They have impaired attention, apraxia, and mild lethargy. And this can actually progress to a global aphasia, both expressive and receptive. That means when you talk to the patient will just look at you blankly. You can't even understand what you say, not to say answer your question. And they can be wide awake and they can just stare at you blankly, yeah? And they are unable to follow commands. And all these can lead on to myoclonus, increased tone, depressed consciousness, obtundation, stupor, and coma. The tempo can, however, be very, very fast. It can progress from just like a mild tremor into like coma within a span of just hours or just 1 or 2 days. So the tempo can be very, very fast. That's why we have to monitor these patients very closely to make sure that we don't miss any ICANS. Okay, so how do we, on the ward round, practically, how do we monitor them? So the ASTCT have come out with ICE2, and this is something that we administer to all our patients who are admitted for CAR-T. So essentially, we test their orientation. We ask them what's the year, what's the month, what's the city, where you at. We score it. We ask them to name 3 objects, and we also score how much they can achieve. We ask them to follow simple commands, and again, we score it. And we test their handwriting every time we do this ICE2 as well. We compare it with what their baseline is like. And finally, we ask them to do some counting. We ask them to subtract 10 from 100 all the way down to 0. And we tabulate all the points and we come out with a score. Okay, and essentially here, if your score is 10, there's no impairment. If it's 7 to 9, it's a grade 1 ICANS. If it's 3 to 6, it's grade 2. If it's 0 to 2, it's grade 3. Now, of course, if the patient is in coma and unrousable, of course, it's 0. Okay, so we use both the ICE2, what is the consciousness level, whether there's any seizures, whether there are any motor findings, whether there's any suggestion, either clinically or neuroimaging or cerebral edema to grade the ICANS scoring. Again, management of ICANS depends on what's the grading of their ICANS. And for patients who have grade 1 ICANS, we would give them hydration. We would definitely image the brain. We would refer to neurology. You get an EEG to make sure that there are no seizures, and we'll start CAPRA for this patient. If the patient has grade 2 ICANS, we would definitely consider steroids to reverse this ICANS. And grade 3, grade 4 ICANS, which is very, very serious, would definitely be managed in the intensive care unit. We would give them steroids, dexamethasone, or its equivalent in methylprednisolone. We will definitely get a neuroconsult. There might be seizures on board. There might be need for more anti-epileptics rather than just CAPRA. And depending on whether or not there's any evidence of any cerebral edema on the brain scan, we may also pulse them with high-dose steroids. Okay. Now, in grade 4 ICANS, which is very, very serious, we actually might even lower the ICP with surgical methods. Right? We have to call the neurosurgeons in. Fortunately, we haven't seen anybody with such serious ICANS in our center. Nowadays, in our center, the moment we detect any evidence of grade 2, we would give them steroids immediately. Okay, so there are risk factors for ICANS, and this is important because if we know that this patient has a higher risk of ICANS, we want to watch them even closer. Sometimes we do like all these ICE2 more than 3-4 times a day. We think they're very high risk. So the disease burden, if the patient has a very, very high level of disease in the body, like blast count of more than 40% for ALL or bone marrow involvement, bulky disease everywhere for lymphoma, we would be very, very careful that they have higher risk of ICANS and CRS. Also, the disease subtype, as you could see from the earlier table, ALL definitely has a much higher risk of ICANS and CRS compared to lymphoma or myeloma. The doses of CAR-T that we use is also very important. The higher the doses, because it expands more, it's also correlating with high risk of ICANS and also CRS. And lymphodepletion also. There was a study that was closed in the US, the Rocket study. Essentially, they had 5 patients die from ICANS, and they gave fludarabine plus cyclophosphamide. So people now have looked back, and actually doing a flu-cy lymphodepletion is also associated with a higher rate of ICANS. Of course, if the patient has seen very intense bridging chemo, there's also a higher risk for ICANS. So all these are things that we have to take into consideration when we plan a patient's CAR-T journey. All right. In the last part of my talk, I just wanted to talk about infections. Infections is actually a very, very important aspect of managing CAR-T patients. And the reason for that is because all these patients that come through to us for CAR-T, they have already been heavily pre-treated. Many of them have seen multiple rounds of chemo, 3rd line, 4th line, 5th line of chemotherapy for ALL and for lymphoma. Also, they must have seen many rounds of steroids, pulses and all that. So they're very, very immunocompromised, and many of these patients actually have failed transplant, both allogenic and autologous transplantation. Okay. Now, in the bigger studies, they actually showed that for infection, any grade of infection in the clinical trials, up to 60% of patients had some kind of infections reported in the clinical trials, and actually quite significantly, more than grade 3 infections were seen in about 32% of patients with lymphoma for T cell, 44% for ALL. That's quite a significant number of serious infections actually. And for XSL, any grade of infection, about 38%, and more than grade 3 is 25% incidence of infection. So that's a very, very high number. So just like the risk of ICANS, risk of CRS, for the risk of infection, there are also certain risk factors. Okay, so once again, the baseline disease, ALL, known to have a higher risk of infection. Number of lines of prior treatment also correlates with infection, not surprisingly, because the immune system is weaker, and they found that more than equals to 4 prior lines of treatment is associated with a much higher risk of infection. Baseline immunoglobulin levels, that means if they're hypogamma-globulinic from the beginning, also associated with higher risk of infection. And how heavy is your lymphodepletion? Again, not surprisingly, associated with infection. CAR-T dosing also. Now, tocilizumab is a little bit not so straightforward. Here, certain studies demonstrate that it's associated with higher risk of infection, but certain studies actually show that it's not clearly associated with increased risk of infection. So a little bit controversial. Yeah. Steroid use definitely associated with higher risk of infection. So these are important things to be careful about for the risk of infection during a CAR-T patient. Okay. Now, from the studies, we know that most of these infections actually do not have an identified pathogen, and within the first 30 days of infusion, bacterial infections were the most frequent infection that was detected. Viral infections were next, and fungal infections were actually quite uncommon. After 30 days, again, bacterial is the most predominant infection, and mainly actually urinary tract infections and viral infections after that, and mainly upper respiratory tract or lower respiratory tract infections. And once again, actually fungal infections in patients who have received CAR-T is actually quite rare, not so common. Okay, so this is a table that actually shows the infection risk in people who are undergoing CAR-T therapy. So the early toxicities all the way to day 28, as mentioned earlier on, actually bacteria is the most important. They also found that actually CD toxin, gastroenteritis, is actually quite common. In fact, the most picked up bug is actually C. diff in certain studies, and pneumonia with encapsulated bacteria and viruses. These are the most common infections in the first 28 days, followed by virus, which is HSV, VZV, other herpes virus, and respiratory virus, both seasonal and intermittent. Fungal in the first 28 days, more often they see Candida and a little bit of Aspergillus and non-Aspergillus mold. This is the first 28 days. And this is because of neutropenia from your lymphodepletion, your steroids, your tocilizumab, and all that lead to all this. Beyond 28 days, what we call the delayed phase, in phase 2 all the way to about day 90, the bacterial infection is actually less, and usually is UTI predominant. Virus, the respiratory virus, HSV, VZV, the risk of all these predominates and carries through even the late phase. But you can see here that the risk of mold infections is actually come down. Okay. Now, pneumocystis remains a problem. That's why prophylaxis is actually important and recommended depending on which guideline or consensus you see. Can be 6 months to 12 years, 12 months, 6 to 12 months duration, because there is this risk of pneumocystis pneumonia. Okay. And this is actually taken from the EPMT guideline, where they actually did some recommendations for antimicrobial prophylaxis for patients who are undergoing CAR-T treatment. So essentially for neutropenia, if you want to shorten the duration of neutropenia, because actually in certain studies, neutropenia can predominate for quite long, into months actually, yeah. So in trials, actually, they didn't really fully mention about GCSF, but EPMT recommends that you should, if you want to shorten, you should only start about 14 days post-infusion, because there are theoretical concerns that your GCSF can actually worsen CRS. So we practice this in NUH. We would not routinely give GCSF for the first 14 days. Beyond that, we will also try not to give unless there's a good reason to have to give, like a severe infection. So also antimicrobial prophylaxis, like your levothoxycin, your quinolone prophylaxis, routinely is actually not recommended. However, on a case-by-case situation, some patients who are very, very immunocompromised, like those with more than 4 lines of treatment, and already had a previous multiple rounds of infection, we might consider, but routinely we don't recommend actually antibacterial prophylaxis. For viral prophylaxis, we do give everybody here acyclovir prophylaxis, and we start from the lymphodepletion all the way to 1 year post-CAR-T, or until the CD4 count is more than 200. PCP prophylaxis, we also practice here in NUH. We give it from the start all the way to at least 1 year post-CAR-T, or until the CD4 count is more than 200. Systemic antifungal, actually, we do not routinely give fungal prophylaxis. However, in patients who have multiple lines of treatment, ALL, history of fungal infection before, we will actually prophylax them with actually like osaconazole or micafungin. Okay? Or patients who are after week 2, week 3, they're still neutropenic, but they don't have any other risk factors, we might give them fluconazole prophylaxis. Now, the role of IVIG is also a little bit tricky, but over here, we do give IVIG if it's less than 5, because we want to prevent infections for these patients. But whether you continue all these when they have prolonged B-cell aplasia later on, every center has a slightly different practice. Yeah. Okay. So this is the final slide of my talk, and I would like to ask everybody if there's any questions. Do key into the Q&A box. I think there is a question. Yeah. Okay. Yeah.
Thank you, Dr. Esther. So we will now proceed with the Q&A session. So Dr. Esther, there's a question. There's 2 questions in the Q&A box now, so you can take them. Yeah.
Okay. So the first question is, what are the advancements of CAR-T for solid tumors? Are there any approved therapies for colon, liver, or pancreatic cancer? So actually, CAR-T for solid cancers are still I think still currently undergoing trials and all that. The results haven't been so good. So I think but lots of work is being done on this. So currently, not to my knowledge, I don't think there's any approved therapy for colon, liver, or pancreatic cancer. So that's the first question. The second question, okay, with the COVID being endemic, are there any thoughts or insights on the safety profile or outcomes of recovered COVID-19 patients, as well as vaccinated mRNA individuals who have undergone CAR-T treatments after recovering from COVID-19 or vaccinated for COVID-19? So thanks for this question. Actually, good question. This is actually undergoing some research in NUH. We actually have a clinical trial looking at COVID vaccination in patients who have undergone CAR-T therapy. So I also hope to be able to answer your question once we have results from that. But otherwise, actually, from guidelines and recommendations, actually, we consider patients who have undergone CAR-T safe to get their COVID vaccination about 3 to 6 months after receiving the CAR-T. So that is for the second question. Third question, from your practice after CAR-T administration, how long will you keep patients inpatient, or will you manage them outpatient but ask patients to stay nearby? So again, a very good question. So in Singapore, I think because we don't have that many patients with CAR-T administration, and we are also relatively new compared to the larger centers in the US. So as of now, at least in NUH, every patient that we give CAR-T to is actually managed inpatient, and we will manage them at least for the first 7 days to 2 weeks in the ward until we are sure that they have gone past the time where there's a high risk of CRS and ICANS before they are discharged. But like when I was overseas on my HMDP, they actually monitor these patients outpatient. They stay very near the hospital, and the moment they have fever, only then the patient comes into the hospital. So this is actually the outpatient management is actually practiced overseas already currently. Yeah. So the next question, are the symptoms of ICANS reversible? So actually very lucky for us, and also for all the patients who undergo CAR-T treatment, most of the time, the symptoms of ICANS are reversible. Yeah, that means all the seizures, all the coma, most of the time they are reversible. Okay, and also because nowadays we are very careful with management of ICANS. Any signs that they are having some kind of ICANS, we would give them steroids already. We don't want to let them progress on to a higher grade of ICANS. So in the reported literature and in our own experience, we have seen that most of the ICANS reverse completely and fully. Okay. The next question. For the guidance, this one, because all the vaccination studies and all take a while, so, and also the number of patients who we have on CAR-T is not very high in Singapore. So hopefully when we have enough data, we will be able to will release all these results. Yeah. So I think that is the last question I have on Q&A.
Yes, that's the last question. So any one of you have any questions for Dr. Esther Chan? Yeah, there's another one that's coming, Dr. Esther Chan. Okay.
Yeah.
She said, thank you, Dr. Esther. Yeah. Okay, if any one of you, yes, there's another one more from Miss Anita Ng.
Okay, so I think currently NUH, SGH, and KK are the hospitals that have given CAR-T. I don't have an exact number for you, I'm sorry. Yeah, because there are 3 centers actually carrying out CAR-T. But in NUH, the adult side, we've probably given about 8 to 9 cases of CAR-T in the last 2 years. Yeah.
Okay. And Dr. Esther, there's one more question that's posted in the chat box.
Okay. So in terms of administering CAR-T, what are the considerations one should consider, especially with, so good question also. Basically, we really have to look at the patient first, and because if the patient has a very high risk of any side effect, we will watch them even closer. Otherwise, for our center, we monitor them at a minimum of parameters, at least 4 hourly, detailed assessment of handwriting and all that, at least twice a day. And any signs that they are well, or there's some kind of grading of CRS or ICANS, then we would step up that monitoring. So we have to be very careful, because we really do not want any adverse events from administering CAR-T to the patients. Yeah. Okay. Okay. So another question: how many times can TOSI be given? So currently, the maximum number of doses we give is up to 4 doses. But studies have shown that if you don't respond after the second dose, those additional third and fourth dose of toxin may not do very much lah. And we've also seen that in our own center also. Yeah, but if you want to say max out, it would be 4 doses. Yeah. Yeah, so for the side effects, what is written in the literature is very true. That means actually one of the most important risk predictors is really disease burden. We have seen that the moment the disease is a lot, we put in the car, they really flare up a lot. We have patients that have to go out to MICU very, very, very fast. High fevers, hypotension, oxygen. So I really believe that actually disease burden is a very, very important predictive tool that the patient would probably flare up from cytokine release and all. Yeah. So in your practice, you wouldn't hesitate to give steroids early on and worry about. So again, actually a very, very good question. So there's always a very fine balance between toxicity and efficacy. So for us, the moment we really think that the patient is not doing well, that means the grading is about grade 2 going on grade 3, we would definitely not hesitate to give steroids. But if like hovering between grade 1 and grade 2, we'll try very hard not to give steroids, because although the study showed that there might not be an effect on the outcome, we really don't want to compromise the patient's outcome. The drug is expensive, a lot has gone in to manufacture this car, so we really try not to anyhow throw in steroids lah. But if it's bordering between something that we really worry about the patient, we would give. Also, if the patient is frail, older, in the 70s, have some pre-existing comorbidities, then we would definitely give the steroids more early rather than later lah. So any second line, if the patient does, this is a very, very good question, the second line treatment. So we are quite fortunate here that we never had to give anybody second line treatment, but it has been reported people have given things like anakinra, cetuximab for actually refractory CRS, yeah, with not too bad responses, I would say. If you look at the paper and the case report, for ICANS, sometimes people even give intrathecal chemo with such a severe ICANS. Yeah? So there are second line treatment that is reported in the literature, but I don't have much experience using second line. Our patients have so far responded to first line treatment. Yeah.
Thank you, Dr. Esther. Okay, so we can still take few questions. Does anyone of you have any more questions? You can post them in the Q&A window. So Dr. Esther can take it from there. Okay, looks like there isn't any more questions coming in. Thank you, Dr. Esther. We have come to the end of our lecture. There's more coming in right now. Sorry, Dr. Esther. Okay, we have, okay, there you go, in the Q&A.
So unfortunately, we don't have a car for AML at this point in time, but this is an unmet need, and if there is a car out there in the clinical trial, I think all the centers here would be really good to have it and monitor closely but there isn't very much CAR-T for AML. Maybe a CD7 CAR, they did have some CRS, but we really don't have experience in AML CAR in Singapore, not very much. Yeah.
Okay, all right. So I don't see any more questions coming in. So we'll take it as the end of our session for today. So so thank you, Dr. Esther. We have come to the end of our lecture for today. On behalf of ACTRIS, we would love for you to join in our November lecture and would like to thank you for your time today. As you sign off, you will be asked to answer a short survey on the event. We will appreciate any feedback that you would like to give us. It does help us to continuously improve our lecture offerings. So see you everybody next month in our November lecture series. Thank you once again to all of you. Thank you. Bye-bye.
Okay, thank you.